There is a price list at almost every hospital in America. It is called the Chargemaster. It lists the official price of every procedure, every medication, every supply. Almost nobody pays those prices. The insured patient pays a negotiated discount. The government program patient pays a different rate entirely. The uninsured patient is handed the full Chargemaster price and told that is what they owe. Same procedure, 3 prices, 1 system. If you walked into a grocery store and discovered that the same loaf of bread cost 3 different amounts depending on who was buying it, you would consider that an obvious injustice. In American healthcare, this is standard operating procedure. The same medical service at the same facility delivered by the same clinician carries a different price depending on whether you are insured by a major employer plan, covered by a government program, or paying on your own. And the most financially vulnerable patient, the one with no insurance and no institutional negotiating power, consistently faces the highest price, not a slightly higher price. Often a price several times larger than what a major insurer negotiated for the identical service. This is not a bug in the American healthcare system. It is the architecture, a pricing structure built not around the actual cost of delivering care, but around who has the market power to negotiate it downward. The people with the least market power pay the most. The institutions with the most market power pay the least. By the end of this video, you will understand exactly how this pricing structure was built, who benefits from maintaining it, and what you can actually do when you find yourself facing a bill designed for someone with no alternatives. Let us start with the document at the center of all of this. To understand hospital pricing, you need to understand the Chargemaster. The Chargemaster, formally called the Charge Description Master, is a comprehensive list of prices that a hospital sets for every service, procedure, medication, and supply it provides. It is the hospital's official internal price list. And for most of hospital billing history, it was completely secret, not publicly available, not required to be disclosed. A document that determined what patients were billed, but that patients had no ability to see in advance. A federal rule that took effect in 2021 required hospitals to post their Chargemaster prices online. Most hospitals complied. In technical terms, publishing files so large and so poorly formatted that they are effectively unreadable by the average patient trying to understand what a procedure will cost. Now, here's the critical thing to understand about Chargemaster prices. They are not what the hospital expects to actually collect. They are the starting point for a negotiation. Major insurance companies negotiate rates with hospitals, typically paying between 20 and 60% of the Chargemaster price. For equivalent services, government programs pay their own set rates, typically well below Chargemaster, and often below what private insurers pay. The Chargemaster price functions as an artificial ceiling, set deliberately high to give room for negotiation with parties who have the power to demand discounts. The only patients who pay anything close to Chargemaster prices are uninsured patients, and, in some cases, patients whose out-of-network treatment is billed at Chargemaster rates. This creates a surreal situation. A hospital sets a price for a procedure that it has no realistic expectation of collecting from any organized payer. Then it bills that price to individual uninsured patients, the people least able to pay it, as their official financial obligation. A study published in the journal Health Affairs found that hospitals collected, on average, approximately 10 to 20 cents on every dollar of Chargemaster charges, meaning the list price bore almost no relationship to actual expected revenue. But for the uninsured patient holding a bill that says they owe $18,000 for a procedure their insured neighbor paid $800 for, the Chargemaster price is very real in its consequences, even if it has no connection to the actual cost of delivering the care. Now let us look at how insurance companies arrive at the dramatically lower rates they pay and why individual patients cannot access those same rates on their own. The negotiated rate between a hospital and a major insurance company is the product of a contract negotiation between two large institutions, each with significant leverage. The insurance company brings volume. It represents a large pool of patients. If the insurance company's network includes this hospital, thousands of covered patients will choose it because their insurance covers it. If the hospital is excluded from the network, if it is out of network, those thousands of patients will generally go elsewhere. That threat of losing patient volume is the insurance company's primary negotiating lever. The hospital brings something, too, in markets where it is the only major provider of certain services, the only cardiac surgery center in a region, the only level 1 trauma center. It has significant pricing power. Patients may have no practical alternative. The insurance company needs that hospital in its network to be competitive in that market. The negotiated rate emerges from the balance of these institutional forces. An individual patient has neither force available. They do not bring volume. They represent one patient, one visit, one bill. They cannot threaten to redirect thousands of patients elsewhere. They often cannot choose a different hospital because the emergency arrived without warning, because the specialist they need practices only at this facility, because geography limits their options. The result of this power imbalance is documented and measurable. Studies comparing what insured and uninsured patients pay for identical services consistently find the uninsured facing prices 2 to 10 times higher than the rates negotiated by major insurers. A hip replacement that costs a major insurer's patient $15,000 in total billed charges might result in a Chargemaster bill of $70,000 to an uninsured patient. Same surgery, same hospital, same surgeon, same implant. The factor of 4 difference is entirely a function of negotiating power. Now, here is what makes this particularly significant in the context of who bears these costs. People who lack insurance are disproportionately lower income. They are less likely to have employer-sponsored coverage. They are more likely to work in sectors that do not offer insurance benefits. They are more likely to be in financial positions where an unexpected medical bill of any size represents a serious hardship. And they are the ones facing the highest prices in the system. Medical debt is the leading cause of personal bankruptcy in the United States. The majority of those bankruptcies involve people who had some form of coverage, but whose out-of-pocket costs, deductibles, and non-covered services accumulated to an amount their income could not absorb. The pricing system does not just fail to protect the most vulnerable. In its current design, it actively extracts the most from them. If understanding how the pricing system rewards institutional power and punishes individual vulnerability just changed how you see your last medical bill. Stay with me, because understanding the architecture is one thing. Understanding why this system has survived decades of documented criticism, largely intact, and what you can specifically do when you face a bill that was not designed around what you can actually pay. That is what comes next. Here is the regulatory history, worth understanding. The current hospital pricing structure did not emerge from a free market. It emerged from a specific regulatory and historical context that created the Chargemaster system and allowed it to persist. In the 1980s, when government programs began paying hospitals fixed rates for specific diagnoses rather than reimbursing whatever the hospital billed, hospitals responded by raising Chargemaster prices. Higher Chargemaster prices meant more room to negotiate with private insurers. More room to negotiate meant higher negotiated rates from private payers that could offset the government program fixed rates. The Chargemaster inflation was a rational institutional response to a change in government payment structure, but it created the specific irony we see today, a price list that exists primarily as a negotiating fiction, but that becomes a very real bill for the least powerful patients. The hospital industry has successfully resisted comprehensive price transparency reform for decades. The 2021 price transparency rule was a significant step, but the implementation has been widely criticized by healthcare economists and patient advocacy groups for producing data that is technically available, but practically unreadable. The American Hospital Association lobbied against the initial rule and challenged it in court, arguing that forcing disclosure of negotiated rates with specific insurers was commercially harmful and a violation of contract confidentiality. The court upheld the rule, but the compliance that Followed has been the minimum, technically required, not the meaningful transparency, the rule intended. This is the familiar pattern. Concentrated industry interest, sustaining a system that produces outsized revenue at the expense of the least powerful participants. What makes healthcare particularly resistant to market correction is that the standard mechanisms of consumer choice do not function in medical emergencies. You cannot comparison shop for a heart attack. You cannot defer a broken leg until prices improve. You cannot take your business elsewhere when your specialty care is available only at one local facility. The conditions that normally discipline pricing through consumer choice, the ability to wait, to shop, to substitute, are absent at the exact moments when the highest costs are incurred. That is not an accident of how medical care works. It is a structural feature of the market that the pricing system was built to exploit. And it is why this system has been profitable enough to resist reform, despite decades of documented consumer harm. Here is what you can actually do when you face a medical bill that bears no relationship to what you expected or what you can pay. First, the Chargemaster price is almost never the final price, even for uninsured patients. Most hospitals have charity care programs and financial assistance policies, required by law for nonprofit hospitals that receive tax-exempt status, that can dramatically reduce or eliminate bills for patients below certain income thresholds. These programs are real. They are available. They are almost never proactively explained to patients at the point of billing. Ask for the financial assistance application at the billing office, specifically and in writing. Second, negotiate directly. Hospitals negotiate with insurance companies as a matter of standard practice. They will also negotiate with individual patients, not always easily, but often effectively when approached directly and persistently. Ask what the Medicare rate for your procedure is. Medicare rates are publicly available. Ask the hospital to bill you at the Medicare rate rather than the Chargemaster rate. Many hospitals will accept this or come close to it for patients paying directly without insurance involvement. The difference between Chargemaster and Medicare rate can be 50 to 70% of the bill. Third, ask for an itemized bill and review it carefully. Billing errors in hospital bills are documented as extremely common, with some analyses finding errors in the majority of hospital bills reviewed by billing advocates. Charges for services not received, duplicate entries, incorrect procedure codes. All of these generate real charges that are real obligations until you dispute them. Request the itemized bill. Question every line item you do not recognize. Fourth, for large bills that remain after negotiation and financial assistance, medical billing advocates exist as a professional service, specifically to negotiate on behalf of patients. They typically work on contingency, taking a percentage of what they save you, which means their incentive aligns with yours. Unlike most of the pricing system we just described, the same procedure at the same hospital genuinely costs 3 different prices depending on who is paying for it. That is not a quirk of an otherwise functional system. It is the system designed around negotiating power, not around the cost of care, not around fairness, and not around the patient's ability to pay. Understanding this does not fix the system, but it gives you the tools to navigate it, to ask for financial assistance, to negotiate the rate, to dispute the errors that the system was not designed to volunteer to you. Share this with one person who has ever received a medical bill that seemed designed for someone else's income. And if you want to keep understanding the financial systems built around institutional power, subscribe to Hidden Truth Files. Hidden no more.